Hello everyone, hopefully you can all see and hear me. I'm just going to wait another minute or two just for any people who are going to be arriving. But I appreciate you're all probably on your lunch break, so I'll be starting in just a minute. Can everyone hear me okay? If you can't, either just give me a wave or if you want to just put something in the chat, that'd be helpful. I think it looks like it's working, so you should be able to hear me hopefully. Let's give it one more minute and we'll make a start. So feel free to put your cameras on if you like. The webinar will be recorded just so that people who couldn't attend can watch it later. So appreciate if you don't want your cameras on, but it's nice for me if your cameras are on because it doesn't feel like I'm just sort of talking to myself in a room. That's always nice. If you could keep your mics off though, unless you have a question, just so we don't get any feedback or weird noises, that would be great, please. So yeah, if you can just make sure your mics are off unless you need to ask a question. Okay, so it's 1 o'clock, so I will make a start because I realise probably you're all on a bit of a deadline. Welcome to this webinar hosted by NCOR on systematic reviews. My name's Daniel Bailey. I'm a research fellow for NCOR, so I do 2 days a week as a research fellow at NCOR, and then the other 3 days a week I'm in clinical practice seeing patients. So the purpose of this webinar was to really give everyone an introduction, a very basic level introduction to systematic reviews, for potentially the purpose of becoming involved in a systematic review that we will conduct as NCOR, or more specifically NCOR-RN, so the NCOR Research Network. But either way, this will hopefully just be a good hour's worth of CPD about systematic reviews, which you then may decide that you'd like to become a little bit more involved in taking the systematic review forwards with NCOR. So as I say, this is going to be recorded, so you'll be able to watch it again later if you do have to leave, if you don't make it to the end. We'll make the recording available, but it will mean that you may appear, if you do wish to ask a question, you may appear on the recording. So if you don't want to do that, please feel free to use the chat, or if you do want to ask a question, I'll be leaving some time at the end, but if it's kind of super relevant to what I'm talking about, feel free to just unmute yourself and just shout out. Apologies if I'm not looking at the camera all the time because I'm just letting people in as they arrive. And then yeah, if you can just keep your mics off while you're not asking a question, just so we don't get any weird feedback, that'd be great. So what I'm going to do next is I'm going to share my screen, and I've just got a presentation just to help guide us through this systematic review topic. So I'll just load up this screen, make sure you can all see it. Just letting a few more people in who are arriving. Okay, can you all see the conducting a systematic review PowerPoint presentation? Maria, I'm looking for a thumbs up as you're the only. Yeah, thank you very much. Thank you. You're the only camera I can see at the moment. So, yeah, I haven't got everyone's cameras on now or anyone. So if you are waving at me, I probably can't see you. So just unmute yourself and shout out if there's a problem. So as I say, my name is Daniel Bailey, a research fellow for NCOR. I'm just going to be taking you through a basic presentation about systematic reviews. Feel free to shout out with any questions that you might have. as we're going along. I'm just going to double check we haven't got any more people who want to come in. No. Okay, great. So the basic plan is I'm going to just go through an overview of what a systematic review is. Then we'll go through the individual stages of a systematic review. I'm going to give you lots of examples of systematic reviews that may be of relevant clinical interest to you, to show how these can inform your clinical practice. And then we'll look more specifically at what would be involved if you were to decide to take part in actually conducting a systematic review with NCOR. And then we'll have a think about some possible topics and ways in which we might be able to continue to discuss that further, should you wish to be involved. And then there'll be chance for any questions at the end, but also we've got some options as to how we might be able to continue this discussion, which will include if you have any further questions, should you think of them afterwards. So what is a systematic review? So if we just want a sort of really texty definition, a systematic review aims to identify, evaluate, and summarize the findings of all relevant individual studies by adhering to a strict scientific design based on explicit, pre-specified, and reproducible methods. So the key here is that it is a systematic review, in that it informs a very specific set of steps in order to conduct the review. And this is different to, say, a literature review or a scoping review or a narrative review, which doesn't have the same systematic step-by-step process to conduct the review. So the aim of a systematic review really is to ensure that the highest probability that all the relevant information has been included. So the systematic review is aiming to answer a research question. That research question could literally be anything. What is the best treatment for neck pain? And then that systematic review, in order to answer that question, what is the best treatment for neck pain, it will attempt to include all the available literature and research that has been published about that topic. And then it will aim to try and synthesize that information in such a way that it answers the question. And by including all the information, it ensures that the answer to the question is hopefully the most trustworthy answer to that question, with as little bias or error in it as possible. And so hopefully, as we start to look at what a systematic review is, it'll become a little bit clearer as to why a systematic review is a good way to answer a research question. But if you just need a sort of simple definition, these are some fairly clear ones, I think. So if we look at research more generally, it's often presented as this pyramid or hierarchy of research. And what we'll see is that systematic reviews and a specific type of systematic review called meta-analysis sits at the top of that pyramid. But if we start at the bottom with what would be potentially deemed the lowest quality of evidence, that is background information and expert opinion. So expert opinion is what one person or maybe a collection of people have to say about a topic, or what their answer to that research question might be. And while their opinion might be very valuable, we have to recognize that that is just one person's opinion, and their opinion is going to be based on their own experiences and their own knowledge, and so therefore subject to a lot of bias and potentially misinterpretation, or simply just mistruth. And so it may be that their opinion is not relevant to our situation and our scenario, so it's not as useful to us. The next level up is case controls or case series or case reports. These are essentially sort of mini research projects on usually just one patient. And so this will be looking at a specific intervention, treatment type, assessment procedure for one patient. And it'll look at how that treatment process worked for that one specific individual. So it's a little bit more controlled than just asking for someone's opinion, because we've got an actual patient to base some sort of objective findings upon. But we also have to accept that this is just one patient. So there are going to be a lot of things that were specific to the context of that patient that won't necessarily apply to our scenario. So we don't know whether the answer that to the question they got is going to be the same answer to the question we have. The next level up is cohort studies. So this is where we're looking at a group of individuals, so multiple patients with the same problem that perhaps received the same intervention. And then we're looking at how that intervention worked for a group of patients. And so potentially the results are going to be a bit more generalizable to our scenario, because it's more likely that a cohort study included a patient that's similar to the patient that we have a question about, compared to a case report where it was just one patient. So cohort studies can be really useful, and they can look at what happens to patients over varying different time periods, responding to various different interventions, assessment procedures, etc. But what cohort studies don't tell us is whether the changes we see in that patient group are due to that intervention, or whether those changes may have just happened anyway. Maybe the patients would have just got better anyway. Because in cohort studies, we don't have a control group. So we don't have a group of patients that we didn't do anything to that we can compare to see whether they'd have got better anyway. And that's really where randomized controlled trials come in. So the controlled bit of a randomized controlled trial is where we have a group of patients who are the same as all the other patients. If you could just turn your mics off if you've joined for me, please. Just check your mics are muted unless you need a question. That'd be great. Thanks. So the randomized controlled trials will include a group of patients who don't receive the intervention. So then at the end of the study, we can compare the group of patients who received the intervention with the group of patients who didn't receive the intervention to make sure that there was a real difference between those two groups. And so that's what a controlled trial is. And we randomize whether the patients go into the intervention group or into the control group. And often there'll be more than one intervention group. So we'll be comparing a couple of different types of treatments with a control group who don't receive any treatment, just to make sure that they didn't get better anyway, or they didn't get worse anyway. So these kinds of trials introduce a lot more control, so that we can be sure that the results are due to the interventions that are happening. But the more control you introduce into an experiment, the less like real life you make it. So potentially the results become less transferable to real clinical practice, because our clinical practices aren't controlled environments and all our patients are very different. We can't categorize our patients into groups quite as concisely as they would do for a randomized controlled trial. They'd make sure that this group of patients was between a certain age and had never experienced these health conditions before, so as not to confuse the results. Well, we don't have that luxury in clinical practice. We just have to take our patients as they are, regardless of what their past medical history, age, societal status, etc. is. So we can't control our patients as well. So sometimes it can be difficult to apply the results of randomized controlled trials to clinical practice. The next level up is critically appraised topics. So this is where cohort studies or randomized controlled trials or case report studies have been looked at, probably in combination with other similar studies, and they've been critically appraised. So they've been evaluated on their merits, they've been judged for their quality, and then summarized. So these might often take the form of guidelines, so clinical guidelines, like you might see the NICE clinical guidelines, for example, on various different health topics. those are critically appraised topics. So this is where someone has looked at the research and then sort of synthesized it and appraised it and critiqued it to try and come up with an answer that is trustworthy and as free from bias as possible. But then sitting right at the top is your systematic reviews, because not only are we taking research, analyzing it, and critically appraising it, we're doing that in a very thorough and systematic way. And we're trying to include all the research. So we're not just looking at bits of it and potentially missing out something that could be really important. We're trying to include all the research so that we know that whatever answer we eventually come to has been formed using all the available information. And a meta-analysis is simply where we look at the results of different systematic reviews to create one sort of final measurement or result. So it's combining systematic reviews in a systematic review. So that's kind of the ultimate level of evidence, if you like. So systematic reviews are great because they provide a high-level overview of research data. You're not just looking at one specific study and therefore potentially taking on the flaws or problems with that study. They answer very focused clinical questions that you can immediately take the results into clinical practice with. As best as possible, they eliminate bias, and so therefore provide high quality evidence, which means it's great for clinicians. And one source of these is the Cochrane Library. So the Cochrane Library is an organization that conducts systematic reviews and provides very clinically focused systematic reviews, and they're all free to access. I'll show you some examples of them later. And they provide very nice author's conclusions, whereby there'll be a summary that's aimed at clinicians, and they also provide a summary that's aimed at the public. So it's written in lay terms, and actually, those are often the ones that I will read as well, because it provides a very immediate interpretation of those results without having to go into the details of the methodology, etc. So I'm going to provide links to the Cochrane Library, but as I say, it's free to access, and there's hundreds of different systematic reviews there, which will have clinically relevant topics for you to look at. So if we just look at the stages of a review, we start off by selecting the topic. So this is really about choosing the question. What is the question that you would like the answer to? And that's something that we determine between us as clinicians and as NCOR for the purpose of the systematic review going forward. We then have to create a protocol. A protocol is basically just a set of instructions as to how we're going to conduct the study. And this will include things like our search strategy, the eligibility criteria for which studies we feel are relevant. And then once we've created that protocol, we then start searching for those studies. So this is an online activity where we're searching databases of research studies on the internet to try and find ones that are likely to have the answers to our question. You then end up with lots and lots of studies, some of which will be relevant, some of which won't. So we then screen those studies for their relevance, and we screen them against the eligibility criteria that we've already decided upon in our protocol. So this means reading those studies and deciding whether they fulfill our inclusion criteria, our eligibility criteria, and we keep them, or whether they're not relevant because they don't fulfill our eligibility criteria and we get rid of them. We then left with a core list of research studies that fulfill our eligibility criteria and are therefore likely to have some useful information. So we then appraise those studies. That means checking their quality. So we do a quality assessment, a risk of bias assessment, depending on what type of research studies they are. And that basically scores them. So we'll have some low quality ones, some medium quality ones, and some high quality ones. So it just helps us weight the information that we get from these studies based on the quality of them. We then need to extract the relevant data from these studies that will help us answer our questions. So that might be, did the patients get better? What was the treatment given to them? What were the age of the patients? What sort of setting were they treated in, et cetera, et cetera. And then finally, once we've got all our data, we then have to synthesize it to come up with an interpretation that helps answer the initial question that we came up with. And then this is how we demonstrate that using all the available evidence, we've used a systematic approach to obtain information that answers our initial research question. So those are the sort of broad stages of the systematic review. So here are some examples, and I did send these out via the NCOR-RN newsletter, so you may have seen these, and if you've searched for your NCOR-RN newsletter, you'll have copies of these. So these are just some recent systematic reviews that I found that were all open access, so you can access the full papers of these should you wish to. But I also provided a summary, so a one-page summary, which I'd used AI to form. And I sent those out as well, so that you don't need to read the whole thing if you may not be interested. So this was an assessment and early investigation of Cauda-Equina syndrome, so a systematic review of existing international guidelines. So this is essentially a systematic review of those kind of second tier level of evidence guidelines and frameworks. So they're already critically appraised research topics, but the systematic review is then taking all those separate appraised topics and assessing them as a group. And so the findings were that if Cauda-Equina is suspected, urgent MRI is essential, ideally within 4 hours. I mean, these are providing ideal guidelines. They're not providing things that are necessarily realistic in the NHS, for example, for anyone who's tried to refer a patient with suspected Cauda-Equina syndrome. But these are the ideal outcomes. Common red flags include saddle numbness, bladder or bowel problems, bilateral sciatica. There's some usefulness in point-avoid residual bladder scans, although they're not 100% helpful, and rectal exams are particularly unreliable, certainly when used in isolation. So what I took from reading this was that actually my current level of Cauda-Equina syndrome knowledge was relatively up to date, and it wasn't something that I needed to worry about in terms of doing lots of extra reading. However, if any of this information was new to me, it might prompt me to just do a little bit more in-depth reading. So, this is where you might have had a patient who perhaps you were a bit suspicious of Cauda-Equina syndrome in clinic. You told them to go to hospital, and then later on that day you might have had a bit of a wobble and thought, well, was that actually the best thing for that patient? So you check on this recent systematic review, and it can just either confirm or make you have a little bit more of a think about whether your actions were most appropriate, whether your current knowledge is completely up to date, whether you perhaps need to do a little bit more reading. And I think for most of us, this kind of information is probably not that much changed since we first learned about it. So we can be reassured that our current practice and current knowledge is probably up to date. So the next one was the impact of postpartum exercises on pelvic floor disorders and diastasis rectus abdominis, a systematic review. So this was looking at the effect of exercises postpartum. So I think this would be really useful when patients have questions. So patients ask, is it really worth me doing my pelvic floor exercises after I've had a baby? And so you can say, well, yes, if you do your pelvic floor exercises, you're going to reduce your risk of urinary incontinence by over a third. So it is going to be super beneficial and super helpful. Or more consequently, if you don't do your pelvic floor exercises, there will be an increased risk you will experience urinary incontinence and pelvic organ prolapse. So you can confidently reassure patients that these exercises are useful to them for postpartum. Abdominal exercises to reduce the width of the muscle gap. So this is that gap that can appear in between the rectus abdominis after pregnancy due to the stretch, referred to as DRA. So patients may come in and say, look, I don't like how my stomach looks now. I've got this gap in between the muscles. Will the exercises make that better? And so we can say, well, yeah, according to the evidence, those exercises will reduce the gap in that muscle. However, we're not really sure whether that actually is going to affect you. So if it's purely for aesthetic reasons, then yes, the exercises potentially will help, but actually there potentially is no consequence for that gap being there, so you don't really need to worry about it. So this kind of review is just providing you with information that you can give to patients should you be asked questions about these topics, so that you can just reliably give them useful information they can act on without having to have any guesswork. But there was no evidence that it would improve existing pelvic floor symptoms. So if the patient said, are doing the exercises now going to help these problems I've had for years? Probably not, unfortunately. It's only going to help with issues as a result of your latest pregnancy. The next one was the effectiveness and safety of manual therapy when compared with oral pain medications in neck pain. So one of our responsibilities as clinicians is to provide patients with potential consequences of having treatment, so side effects, but also potential consequences of not having treatment. So if a patient has neck pain, they've got a few options. They could do nothing, which they've probably already tried. They could take pain medication, or they've come to see you for some manual therapy, with manual therapy being one component of osteopathy potentially. So manual therapy was slightly more effective than medication for reducing neck pain. So immediately we can advise them that compared to medication, the manual therapy that you would deliver as an osteopath as part of your package of care is going to be more effective than taking that pain medication. However, in the long term, the differences were less consistent. So that means that manual therapy is at least as good as pain medication in the long term, but also has fewer side effects. So in the short term, manual therapy is better. In the long term, it's probably just as good, and it's safer. So again, we can just give the patient all this evidence-informed information so that they can make a reliable decision about consenting to treatment because they've had the information to give informed consent. Next one was the effective of spinal manipulative therapy in treating spinal pain does not depend on the application procedures. So this was looking at not whether manipulation worked, but did it work differently depending whether you performed it very specifically. So if you were trying to manipulate a specific segment in a specific direction with a specific application or direction of thrust, those sorts of details. And what it found was that spinal manipulation was effective at reducing pain and function, but that it didn't really seem to make much difference on how that manipulation was performed. So the procedural details didn't make a huge difference to the reduction in spinal pain or improvement in spinal function. So I think as a clinician, this sort of means I perhaps don't need to worry too much about the subtle minutiae differences in application technique. If I were an educator involved in teaching other people to do these techniques, then it means that perhaps we don't need to focus as much on that because the outcomes are potentially not going to be that much different. It might be that I start to ask questions of this research. Did they use very experienced clinicians to judge these differences, or was it more junior, inexperienced clinicians? Because potentially that would have had an impact on the effectiveness of these subtle differences in technique. So there's always potential for interpretation of the results, but I think the overlying message here is that potentially those differences do not make enough of a change in the patient outcomes. But the good news is that overall, spinal manipulation was effective in spinal pain treatment. Next one was mechanisms of manual therapy. So how does manual therapy work? So again, manual therapy being one component of osteopathic care. And it proposes it works through a combination of mechanical effects, so the moving of joints around has changes on tissues. Then there's the neurophysiological responses, so activation of different neurological systems that can reduce pain signals. And then the psychological influences, so the sort of contextual factors of the therapist interaction and the patient's expectations, beliefs, things like this. So again, you'd look at that, you'd say, does that sort of conform to my existing beliefs? If so, great, you're currently practicing in a contemporary evidence-based way. If not, maybe it will give you some direction as to further reading to explore whether there are some other areas that you've not considered. So you can either be reassured you're practicing in line with the evidence base, or it's a good source of further reading and professional development. And reviews are not always just about evaluating treatments. So this was a systematic review I did a few years ago, and what we were trying to do was define adherence to exercise. So exercise interventions are used lots and lots in randomized controlled trials. So patients with various different musculoskeletal problems are given various different exercises, and then they're observed to see if they get better. Um, but obviously, they're only going to get better if they actually do the exercise. So at the end of the study, if you've got patients who haven't got better, we're not sure whether that's because they just didn't do the exercise in the first place, or whether it's because the exercise just simply wasn't appropriate for their problem. So our project was to develop a way of measuring exercise adherence, because if you just ask patients if they did the exercises, you get very socially desirable answers, like if you ask patients if they smoke or drink alcohol. So you don't always necessarily get the truth. People will under or overestimate. So before we developed a measure, we wanted to see, was there a definition of adherence that already existed, which we could use to create this new measure of adherence? So we conducted a systematic review to comprehensively explore all the literature on adherence to see if we could find a definition. We weren't looking at treatment interventions or outcomes. So we looked at things like, was there a specific definition or quote in the research paper that they cited from another source? We looked at ways that they perhaps measured adherence with the patient. So the time they spent exercising, whether they turned up to classes or not, how many sets or reps they did of the different exercises. We looked at how adherence was valued. So did patients have to complete 100% of their exercises to be classed as adherent, or did they just have to do half of them and then they were counted as having done their exercises? And we also looked at the ways in which adherence was measured. So did they use diaries they filled in at home? Was it just a register when they attended to classes? Was it a questionnaire they filled in? Things like this. So this was a systematic review to look at something quite different to what's typically explored. So they really can be used to answer any question that you're interested in. So here are some Cochrane library systematic reviews. So this was manipulative therapies for infantile colic. So this was published back in 2012, so it's quite old now. So typically you'll find that Cochrane reviews are updated roughly every 10 years. And you'll be able to see there's a version history, so be able to see if it's due for an update or if it's being updated. Interventions for preventing and treating lower back and pelvic pain during pregnancy. Manipulation and mobilization for neck pain contrasted against inactive control or other active treatment. Manual therapy and exercise for rotator cuff disease. Exercise and mobilization interventions for carpal tunnel syndrome. So lots of really clinically relevant systematic reviews here. And while they're not just specific to osteopathy, it's very likely that some of these reviews looking at things like manipulation and mobilization will have included randomized controlled trials that featured osteopaths or other research studies that featured osteopathic care, but have combined it with other therapies as well. And then things not necessarily specific to manual therapy or osteopathy, but again, something about providing you with information that you're quite likely to be asked by patients. So during the COVID pandemic, patients will have said to you, what do you think of these COVID vaccines? Should we be taking them? Are they safe? And you can base your opinion on what you've read in social media and the Daily Mail, or you can base it on a systematic review that's looked comprehensively at all the published research and evaluated it on its merits via a systematic review. And so you can say, well, 50% of them do this, 20% of them do this, there's a risk of that, there's a risk of this, they work in this many cases, and you can give more objective data. If I could just ask you if you just double check your mics or just muted for me, please, just so we're not getting any background noises, that'd be great. Thank you. And so what they do in the Cochrane reviews in particular is they provide a nice conclusion, because they are quite comprehensive documents. So reading the whole thing is time consuming, but they'll provide authors' conclusions and they'll do a lay summary as well, specifically designed for patients. So they can be things you share with your patients as well, because they will be able to read a portion of it easily. So this was a systematic review looking at steroid injections for knee osteoarthritis. So the summary was it remains unclear whether there are clinically important benefits 1 to 6 weeks after corticosteroid injection in view of the low quality of included trials and the large amount of heterogeneity, which just means the studies are all very different, and the likely presence of small study effects. Intra-articular corticosteroids should therefore be considered experimental in knee osteoarthritis and not be routinely used until adequately powered and properly designed trials clearly indicate a short to mid-term benefit. And if we look at what they really based that results on, so the key results were people who received an intra-articular corticosteroid injection rated their improvement in pain to about 3 on a scale of 0 to 10. People who received the placebo treatment rated their improvement in pain to be about 2 on a scale of 0 to 10. So when compared to placebo, a corticosteroid injection is minimally more effective than a placebo. However, if you were a patient and you were currently reporting your knee osteoarthritis pain as being 8 out of 10, you'd probably be quite happy about having a treatment that would reduce that 8 out of 10 pain scale to a 5 out of 10 pain scale, which is what the intra-articular corticosteroid injection would achieve. So these are the sorts of discussions you can have with patients that, yes, it potentially might reduce your pain from your current pain scale of 8 out of 10 to a 5 out of 10, but that's only slightly more than the placebo treatment. So you need to weigh up whether the risks of that steroid treatment are worth the potential small additional benefit to the placebo effect, which might be achievable with other treatment interventions. So it really is going to depend on that individual patient's circumstances, what treatments they've already had, what their feelings are towards having an injection, what their feelings are towards trying other treatments. But it just gives you the information to start these discussions to really help direct the patient along a treatment route that's most suitable for them. So these are examples of Cochrane reviews, which are all freely available from the Cochrane website, and the link was on this page, which I'll share the PowerPoint with everybody, but you'll have it on the video as well. But a Google search for Cochrane reviews will take you there. This was another large systematic review that was conducted in 2020, I think. And this looked at all treatments for musculoskeletal pain in primary care. So this is NHS delivery, but in primary care. So everything from medication to surgery to manual therapy to exercise therapy, advice, etc. So again, it just helps provide information to patients. So if a patient has a question, is surgery going to be helpful for my back pain, knee pain, etc., you can say, well, no, there's actually very limited evidence that you're going to be any better as a result of having surgery. However, there's very strong evidence that exercise therapy is going to be really helpful for your knee pain. And as it carries far fewer side effects and risks, it'd be a good idea to start with that first and see if that works before you move on to considering something like surgery. So it just helps to provide that information, objective, bias-free information to patients so that they can make informed decisions about their care and treatment, and you can make informed decisions about the most appropriate care and treatment. So the links there to this study, this is quite a useful one. So what would be involved in actually conducting a systematic review? So initially, there would be some attending of training courses. These would all be online, some of which would be videos that you just had to watch in your own time. And then there'd be some follow-up webinars where you were able to ask questions and discuss the content of these training videos. And there'd be probably staged training so that you'd undergo a little bit of training for each of those different stages we discussed about a systematic review, and just so that you're, doing what's relevant to the next stage of the review rather than having to learn everything at the beginning and remember it as you go along. So there'd be a few hours of different training courses, depending on your existing level of knowledge. But this is something that someone could undertake who's never done any research before. We'd provide the necessary level of training for you. There'd be a few other training activities, such as a few sort of practice activities and dummy runs of doing some of the various stages of the review. You'd be required to reply to ongoing emails and just continue to communicate with the rest of the team throughout the process. We're going to explore using WhatsApp as a means of perhaps just doing this a bit quicker so that we're not adding to our email inboxes too much, and just a way of being able to get a quick response to questions should you be part way through a stage of the systematic review and you've got a quick question. How do I do this? What do I need to click on to get to this menu? And hopefully we'd be able to reply to those sorts of queries quicker for you so you can get timely assistance when you need it. There would be deadlines, because obviously it's a project that we need to continue moving with, but these would be agreed with everyone taking part. So it wouldn't be a case of me saying you've got to do this by this date. We would say, look, I think I can reasonably look to complete this by X, Y, or Z time. And so we mutually agree those deadlines, but there would be deadlines we'd need to work to. We do have budget to pay for involvement within the systematic review. And now we're not pretending that this is sort of remuneration comparable to your normal pay. It is more sort of just compensation for your time, really. So each stage would be broken up and there'd be a compensation payment for your involvement in that stage. And then that would accumulate as you went on. I think someone just had a hand up for a question, so yeah, feel free if you'd like to ask that question. If you just unmute, somebody put their hand up. If not, doesn't matter, I'll move on. But feel free to shout out if the question comes back to you. And so, as well as getting access to lots of free CPD, which would count towards your CPD requirement, you'd get payments for completing the various different training stages. And then, should you complete all of the stages and help us write the study up, then you would be named as an author on that, and we would submit it for publication in a peer-reviewed journal. And so that would be what would be involved. The specific stages would look a little bit like this. So this has been based on a 1 year timeline. Again, research projects tend to be a bit like building projects. They always run over on time. But if we aimed for a year, then there'd be training program and discussions to develop the research question, which might be over the period of a month. Then we do something called PPIE, which is patient public involvement and engagement. So because these research projects are generally for the benefit of patients and public, it's good practice to involve them at a very early stage to get their opinions on the research, to see how it could be shaped to better provide for patients and the public in the final outcomes. So there'd be an element of engagement and consultation with patients early on. We then develop the protocol. So this would be the search strategy. What search terms are we going to use to identify the research that we want to answer our question? What are the eligibility criteria? So what would a study need to possess in order to be included? And what would a study need to possess or not possess to be excluded? And that's how we screen the studies to keep in. What data would we want to take from those papers when we've actually screened the relevant ones? So, what conditions did the patients have? What were their ages, genders, what part of the country did they come from? What setting was the treatment delivered in, if it was a treatment, who delivered it, how was it delivered, over what time frame, things like that. Then we'd actually conduct the first round of screening. So this is where we just look at the title and the abstract, and we try and decide whether they should be included from the just reading the title and abstract, because it's obviously a lot quicker. If we're not sure, we just include them anyway at that point. And then we do the full text screenings. This is where we read the whole paper and decide whether it's relevant or not, based against our inclusion exclusion criteria. And then we've ended up with a core list of papers that we want to include. The number of this can vary. Sometimes it might be 10 papers, other times you might end up with 100 papers. Obviously, the fewer the better, but you don't want to sacrifice missing out on really valuable information. And then we assess the quality of those finally included papers. So we'll do a quality assessment and a risk of bias assessment. And these are essentially tools, so questionnaires that you sort of ask questions of the research study. So if they're randomized controlled trials, you'd ask things like, was there a control group? And you'd have to check that a control group was used. Were participants randomized to intervention and control groups? Yes. Were the researchers blinded to the randomization? Yes. Were the researchers blinded to the intervention and control group? Yes. Were the participants blinded? Yes. And so then you've got yourself a double-blinded, randomized control trial. And so you're starting to evaluate that study. Then we'd extract the data. So this means pulling out all that information and recording it in a table. And we have specific software that helps do that. And this is an area that AI is starting to do a lot. So it starts to sort of extract the more basic information, like the date of the study and the time frame it took, things like this. And then we analyze the data. So we synthesize all the information we've taken from those papers to try and find an answer to our original question. And then we write that up into a manuscript and we submit it for publication so that those results can be shared with patients as well, but obviously with other clinicians and researchers. So we need to discuss a topic. There was a research study done recently which investigated what osteopaths thought were priorities for research. And based on the preliminary results of that study, I sent a questionnaire around to NCOR-RN members saying, what sort of things were you interested in? And what came back as most popular was looking at the effectiveness of hands-on osteopathic techniques. So about 75% of people said this would be their preferred topic. This is a really large topic, and we'd probably need to come up with a much more specific question. And we'd also need to decide whether there was enough research to actually answer that question, and whether actually we'd be using research that was for other manual therapies or other therapies. And so that might not answer the question of osteopathic techniques. And obviously defining what those are starts to become complicated. But this is certainly an area of interest to a lot of people. The neurophysiological effects of osteopathic treatment, again, similar and also similar to things that have been done before. So there's been a lot done about spinal manipulation and the neurophysiological effects of spinal manipulation. And again, a lot was discussed in the paper, the systematic review that I included in the newsletter recently, that living review of the effects of manual therapy, that discusses a lot of the neurophysiological effects of manual therapy. How different we decide that is from osteopathic treatment is something to discuss. Strategies to prevent a sedentary lifestyle in patients. So this is sort of public health messaging. We do have a public health project ongoing at NCOR at the moment, so this would tie in quite nicely with what we're looking to do. And we're looking to provide a training course to osteopaths to help engage their patients with public health topics such as weight loss, smoking cessation, physical activity, things like that. Patient safety in osteopathy. There are existing research studies. So there was the Chrome study a few years ago. NCOR do a complaints and concerns report every year, which looks at this sort of information. So there is existing data. Whether we decide that that data is sufficient, we don't need a systematic review, or whether it would be useful to combine all of that data into a review. These are the sorts of things we could investigate. So that's the end of the presentation. I'll close down the PowerPoint in a second. What I was proposing was so that people can continue to discuss this should they're interested, I have started a WhatsApp group for NCOR. Supposedly, if you click this link, it should allow you to join the WhatsApp group. I haven't tried this yet, so it may work, it may not. If not, you'll have to email me and we can try it a different way. But I thought that might be the easiest way rather than having to email back and forth. And then if someone puts a suggestion, I think this would be a good systematic review, and 50 people give it a thumbs up, and we know we're obviously onto a topic that's worth pursuing further. Or if you've got questions about what a systematic review is or what it would involve that I've not answered and you didn't want to ask in this webinar, then you can stick them on the WhatsApp group. Alternatively, you can email me by replying to any of the newsletters that I've sent out from NCOR-RN, or my emails on the first page of this PowerPoint, which I'll be sending out to everybody. So I'll close this down now, and then I can double check if there are any questions. And I'll just open up the chat. So feel free now to ask any questions, either by sticking your hand up, shouting out, or you can write them in the chat now that I can see it. And I'll do my best to answer them. How many hours a week might be involved in this task? Yeah, good question. So it will vary. So there'll be many weeks where there's potentially no hours involved. So and then when we're doing the reviewing processes, it will be slightly more time consuming, but it will be structured so that you don't necessarily need to do it per week. So we might say, okay, if we say for the screening stage, for example, okay, there are 6 people doing this systematic review, and we've got 30 papers included. So each of us has got to review 5 papers, reviewing or screening that paper. So doing a full text screen of that paper might take 30 minutes, for example. So can we all agree that within the next 3 weeks, you'll all manage to screen your 5 papers? So you've essentially got 2.5 hours worth of work to do in that next 3 weeks. So for that 3-week period, you can either do an hour a week, or you can do 2.5 hours all in one day. There'll be sufficient flexibility, I would say, in order that you're never sort of having to commit a lot of time on a weekly basis. There'll probably be periods of time where you have got a day or two's worth of work to get done in a month, something like this. Yeah, it might be that we schedule some training, and there's a training session for 2 hours every week for 3 weeks just to get the training done. So that might mean you've got to do something. But I'd certainly say it's unlikely to be ever more than half a day in a week. Ideally, we try and keep it to a couple of hours to fit a training course in, so that you can do that either in an extended lunch hour or after work without it impacting too much on the rest of your day. Yeah, I hope that's clear enough. It was a little bit vague, but it will vary. But ideally, we appreciate you're never probably going to have more than half a day a week that you give, so we wouldn't really expect that much. And ideally, we'd make it flexible so that you've got maybe half a day or a day's work to complete over the period of a month, something like that. I missed the WhatsApp link. Can you put it up again, please? Yeah, what I'll do is I'll send an email out to everybody, which has got a copy of the PowerPoint and my email address and the links to the WhatsApp. I had real problems logging in with no meter, so I only just managed to get in with a yeah, there should be a recording available, so it's being recorded. I think it takes Microsoft Teams a while to sort of download it all. But then what I'll do is in that same email, I'll put the link to the recording. So you won't receive an email straight away, because I think it normally takes a while for Microsoft Teams to sort of save the recording. But once the recording's saved, I'll send an email out with a link to the recording, a link to the WhatsApp, an attachment of the PowerPoint. So you'll have everything. Will the training be in the evenings? Possibly. So ideally, it would probably be at lunch times. the live stuff would be at lunch times, because that's when I'm working. If it was that people could only do evenings, then we could potentially schedule some evening sessions. But a lot of it would be done in your own time. So it would be pre-recorded training, and you would just be watching YouTube videos or similar in your own time. So you could do that whenever you liked. But yeah, there might be some live attendance required that might be during the day, but it wouldn't be huge amounts, I don't think. How many people would you like to have per systematic review team? Are we thinking of having several systematic reviews happening at the same time? Wow, several systematic review. That would yeah, I wasn't thinking of that now. So I was thinking really of focusing on one systematic review. Um, and so, yeah, I mean, I suppose if we had a lot of interest, we could look at conducting multiple systematic reviews. Realistically, we're probably looking at around 6 people being involved. But that doesn't mean that more people can't start the process, because I envisage that the number of people that start the process will be more than that finish the process, because inevitably people will realize actually this isn't for me, I'm not really interested, or I simply haven't got enough time to commit to this. And so there will be people who inevitably drop out. So certainly would take more on than the initial 6. And if we end up with lots of people really committed, then yeah, maybe we could split it and do multiple systematic reviews if we have sufficient numbers. Any more questions, or have I not answered any of those properly? In which case, please feel free to stay. Training in the evenings. Here's one more. How soon would this potentially start? So ideally soon. So sooner the better, really. So what I'm hoping is that there'll be a little bit of discussion now, possibly on the WhatsApp, if we can get that working. Hopefully people will sort of throw some ideas around that they'd like to see a systematic review cover. But yeah, as soon as we've got people who are ready to start, then we can start the training. So I think I've suggested August in the timeline on the PowerPoint, and I think that would be realistic. I've still got to put some basic training together, which won't take very long. But yeah, realistically, we'd probably start after the summer, because during the summer holidays isn't really a good time to start anything. So I'd realistically say probably after the summer. So September, end of August, September, I think would be the earliest that we'd realistically start. How do we show interest? Ideally by registering for the WhatsApp group, because I think that's going to be the easiest way of monitoring rather than sort of sending everyone lots of emails. So providing that works, by registering with the WhatsApp. If WhatsApp's just something you can't do, then you can just email me, and I'll include you in it in an email chain instead. But I thought we'd try WhatsApp, as that potentially going forward might be an easy way of communicating once the systematic review starts. Okay, well, thank you very much, everybody, for attending. I hope that was useful. Please keep an eye out for an email, which I'll send out shortly, which will include the recording, links, PowerPoints, etc. If you have any more questions, feel free to email me or wait until hopefully the WhatsApp link works. But otherwise, just keep your eye out for further updates via the email. Thank you very much. I hope you enjoyed it. I'll hang around if
Sorry,
anyone's
one
got
last
any
thing.
questions, but feel free to disappear back to work. But I'll hang around in case anyone's got any more questions. Thank you very much.
I'm not sure if you can hear me. My chat
I
isn't
can hear you.
working for some reason. Are you happy with me sharing the recording? I have a friend who isn't here, and I think she'd be interested.
Yeah, yeah, absolutely. Yeah, just forward the link on once I've emailed it over.
Cool. Thanks very much.
No problem. Thanks. Okay, thanks everyone for your messages. If there's more questions, I'm going to end the event now and I'll get the recording out to you as soon as possible. Thank you very much.